Today we're talking about vent management in the critically ill trauma patient. So a couple months ago, I'm up in the ICU minding my own business and I get a call. And the call is, can you come down to the ED? Because we have this critical trauma. Came into the ED after a high-speed MVC. They're hypotensive, we're transfusing, they're bleeding, they need to go to IR, but they're currently setting 70% on an FiO2 of 100 and a PEEP of 10. Please advise. Now, as I'm walking downstairs, I'm thinking to myself, which patient with refractory hypoxemia would I rather manage? An ARDS patient or a critical trauma patient? And the answer is, I think most of us, me included, are more comfortable managing refractory hypoxemia and ARDS. Why? Well, we do it more often. Also, we have these lovely protocols for ARDS management, and the sick ARDS patients, not all the time, but a lot of the time, their lungs are their biggest problem. The sick trauma patients, we don't do it as often when they're truly refractory hypoxemia. We don't have a nice protocol that we can follow, and if they are sick enough that their lungs are bad enough that they're having refractory hypoxemia in the first place, they probably have multiple other really, really bad injuries that we need to be thinking about simultaneously. So I get to the ED, and this is what I'm looking at. 25-year-old guy, unknown history, high-speed, rollover MVC. He'd initially come in hypotensive with a GCS of 14, gets intubated pretty much right away in the emergency department for hypoxemia. They got some imaging. Small subarachnoid, nothing that exciting. C-spine was normal. Lungs don't look so good. Lots of pulmonary contusions, mainly on the right side. Bilateral pneumothoraces. He's already gotten bilateral large bore chest tubes, and looks like little apical pneumos left, but nothing big left. And then lots of hemoperitoneum and active extrav going on in the pelvis. So they've been resuscitating. He's still pretty hypotensive, even with the blood they're giving him. But more importantly for me at that very moment is that his SATs are 72%, his PEEP is 10, his FiO2 is 100. What now? The first thing that we need to help us know what to do in this what now moment is 1. Reading the trauma vent. Vents are not just therapeutic tools. Vents, it turns out, are actually extremely useful, I would even say critical diagnostic tools that will help you in any patient on a vent figure out what's wrong with them. But in trauma patients, it's particularly critical that you use the vent to help you in your differential diagnosis for why they're hypoxemic. Now, when you're trying to read a vent in a trauma patient, it's key to do this immediately after you intubate them. Why? Well, the first thing is, they're still paralyzed at that point. And reading a vent is much easier when the patient's paralyzed, just like reading an EKG is easier, much easier when the patient's not flailing around. But the other thing is that if you're trying to troubleshoot hypoxemia in a trauma patient who's vented, you need to have a differential diagnosis. And the way you're going to get that differential diagnosis is by reading the vent. It's the same idea as if you have an, undifferentiated shock patient. You walk in the room, what is the very first thing you do? You start ultrasounding them. Why? Because you don't know what you need to do next until you can get a differential diagnosis. So before you do anything, try to figure out what you're dealing with. And this is why step 1 is you've got to read the vent. So let's talk about reading the trauma vent. The easiest mode to have the ventilator in to read it, not necessarily the mode that you're going to want to keep them in, but just to read it, it's often easiest if they're in a volume control mode. Then, as always, when we're reading a vent, we are comparing the part of the vent where we tell the vent what we want to happen, where we enter the settings, with the part of the vent that tells us what is actually happening, which, like in real life, may not be the same thing as what we want to happen. Now, the next thing we do when we're reading the vent is we look at the peak pressure, because this is really going to help us in our differential diagnosis. But a peak pressure is a totally meaningless number without the context of the plateau pressure. So you're going to press the inspiratory hold button, you're going to get a plateau pressure. And as a refresher for what these are, what's the difference between a peak and a plateau pressure? The peak pressure is the highest pressure detected anywhere in the system, all the way from the ET tube all the way down through the alveoli, whereas the plateau pressure, that is the highest pressure that the alveoli are seeing. So when you do this on a vent, you're going to get a waveform that looks something like this. That is your peak pressure, your plateau pressure, and your plateau pressure really, that's telling you about lung compliance. How much pressure does it take to inflate the lungs? And the difference between your peak and your plateau pressure, that is telling you about resistance. How much pressure does it take to get the air to the lungs? Now, whenever you're thinking about this, in any vent, but certainly in a trauma vent, it's really important to understand that the vent cannot tell the difference between transthoracic and transpulmonary pressure. Meaning, if your plateau pressure high, if the compliance is poor, it could mean that your lungs are poorly compliant, that your high transpulmonary pressure is high, or it could mean that there's nothing actually wrong with your lungs, but your transthoracic pressure is high because something is going wrong with the thoracic cavity. And the vent cannot tell you which one of those things is the case. So it's important to remember that. Okay, so that's our little refresher on peak versus plateau pressure. Now let's talk about how these numbers can help us in the differential diagnosis of the acutely sick trauma patient. So what about the situation when you have a high peak pressure and your plateau pressure is also high? The number one thing you need to think about here is if you have a large pneumothorax that's not decompressed. Now, even if you have a chest tube in, this may still be your problem. It's possible your pneumo's on the other side. It's possible that maybe your chest tube is too small to keep up with how fast the pneumothorax is accumulating, especially if you've just started them on positive pressure ventilation, or somebody's been going up on the PEEP and maybe you need a bigger one. Or maybe you have a chest tube and it's big enough, but it's not patent because it's clotted with blood. So this is when, first thing you do, check for an expanding pneumothorax, troubleshoot your chest tubes, make sure you don't need more of them. 2, abdominal compartment syndrome. So this is the issue of the ventilator is measuring a transthoracic pressure, which is elevated, right? So your peak's high, your plateau's high, and it's because your abdominal pressures are through the roof. And I've actually a couple times diagnosed abdominal compartment syndrome, or at least started thinking along those lines, because my high peak and high plateau pressure alarms started going off. And so that's another thing that can absolutely happen in these patients. And if that's your problem, there is nothing you can do on your ventilator to fix this. You need a surgeon to take the patient to the OR because there's nothing you can do about that situation. Okay, so it's not a pneumothorax. You don't think your patient has abdominal compartment syndrome, then the other possibility is just a lung injury situation. And in this case, it's really the same reason why you have high peak and plateau pressures in ARDS. Injured lungs are poorly compliant lungs. And in the acute trauma patient, the reasons you may have lung injury physiology is either you have a bunch of pulmonary contusions or your patient massively aspirated somewhere in this entire process. Either way, lung injury will give you a high peak and a high plateau, but check for pneumothorax abdominal compartment syndrome first. Okay, what about the differential diagnosis now for the situation where our peak pressure is high, but we check a plateau pressure and our plateau pressure is normal or even low? What might be happening here? Well, one possibility is that this pattern is just indicative of high airway resistance because the patient has baseline asthma or COPD. I mean, these patients come in, and it's not like we have time to get a history from them before they get intubated, so we have no idea. And if you have some pretty bad asthma to begin with, and then you get in a car accident, aspirate a bunch of stuff, and get intubated, your asthma may start acting up. So that's certainly a possibility. But the possibility that's more specific to trauma that you need to be thinking about is it an issue that you have a bunch of blood clots gumming up your tube, gumming up your airways? And I get particularly concerned about this if I have a patient with a bunch of facial trauma. Now, keep in mind, you may not see a bunch of blood necessarily coming out of your ET tube because it's possible they aspirated a bunch of blood prior to intubation, and now the blood clot's just sitting there, not necessarily actively bleeding. This can still be an issue, and this is when you want to bronch the patient. what are you trying to do when you're bronching this patient? So this is just going to be a quick and dirty bronch with two goals. The first is to remove any big blood clots to help their oxygenation. The second one, though, is to see if you can localize the bleeding. Because sometimes what you'll see is just bleeding everywhere. Everything is bleeding. And if that's the case, if you're just seeing diffuse bleeding, now might be a good time to try nebulizing some TXA to see if that helps, or certainly won't hurt. But if you do see a localized area of bleeding, that is a very useful piece of information. Not because you personally during the bronch are going to fix that, but because you need to tell that to your surgeons, to IR, because maybe there's something they need to embolize. Maybe the patient might end up needing a lung resection. That is a useful piece of information. Make sure to convey it to the rest of your team. Now, what about the situation when you have a low peak pressure and your plateau pressure is really low? Now, if your peak pressure and plateau pressure are low, it's possible that their lung compliance is amazing. But if I'm looking at a terrible looking chest x-ray with pulmonary contusions everywhere and they aspirated massively, if that's my chest x-ray, their lung compliance probably isn't that amazing. And so this is actually making me suspicious that what's going on here with this low peak and low plateau is that I have a big air leak from my chest tube. And this is when I need to start looking at what is the tidal volume they're actually getting? What is the expiratory tidal volume compared to the tidal volume I set? Because if they're not matching, if I tell the vent to give them a tidal volume of 500 cc's, but then I look at my vent and they're only getting, 200, 300 cc's, this is a problem. What's happening here? Well, in this situation, the vent is like, okay, I'm going to put 500 milliliters of air into their lungs. But then 200 milliliters of that air promptly exits through the chest tube and does not, in fact, inflate the lungs. And that's why you're not getting your tidal volumes. Now, if you want to confirm this, you look at your waveforms. You take a little deeper dive to figure out, is there an air leak going on? So you're going to look at your volume waveform and then your pressure and flow volume loops. And this is what they look like on a normal day. And on a normal day, what is supposed to happen? Everybody is supposed to return to zero. Your expiratory tidal volume curve returns to zero at the end of the breath, as do your pressure volume and flow volume loops. Everybody returns to zero. Now, what do these look like if you have an air leak? Well, the first thing that you're going to see is that nobody returns to zero anymore. Your volume curve does not return to zero. Neither do your pressure or flow volume loops return to zero. And how far from zero they end, that is your leak volume. And so your expired tidal volume is actually lower than the tidal volume that you set. Then at the end of this breath, you'll see this little ditzel in the volume waveform, and that is the vent recalibrating, because the vent is not an idiot. The vent knows that you didn't expire that entitled tidal volume, and so it's recalibrating and setting a new 0 point. And so that is what these vent waveforms are going to look like when you have any kind of big air leak. But in this specific situation, in this trauma patient, we're worried that they have a big air leak from the chest tube. Now, what do? What if you're like, oh yeah, I'm trying to give them tidal volumes of 500, but they're only getting tidal volumes of 200? This is a problem. So what you're going to do here is you're going to have the vent compensate. And there's a couple different ways to do this, but probably the easiest way to do this is to use a volume targeted vent mode. Now, annoyingly, depending on the brand of ventilator you have, the name of a volume targeted vent mode might be different. So some vents call it volume targeted ventilation. That is very helpful. But others call it volume guarantee. Some call it PRVC. Some call it VC plus. And so you don't totally know the name of it in the vent that you have, but find out. The point is that what you want is some mode where the vent intelligently and dynamically targets a particular tidal volume. And you'll see them use this kind of vent mode frequently, for example, in neonatal vents, when they all have these little bitty babies and their ET tubes don't have a cuff. So you can imagine if you're trying to do positive pressure ventilation through an endotracheal tube with no cuff, you have leak problems. And so that's why a lot of the literature on this and a lot of the modes that are relevant here, you'll actually see in the neonatal patients because they're used to dealing with big air leaks. So find a volume-targeted vent mode, put your patient on that. Now, sometimes it's the case that the leak is just so big that it overcomes any ability of the vent to compensate. And when you start getting at a leak of like 50, 60, 70%, you may be hitting your limit. If that's what's happening, your patient probably has a big enough lung lack that they're going to end up in the OR often anyways with somebody needing to deal with that chest. But what you can do in the short term, stick them on a volume-targeted vent mode. So to summarize, how we're going to use reading our vent to help us in differential diagnosis and troubleshooting initially of hypoxemia in our patient is we're going to look at the peak and the plateau pressure. If we have a situation of a high peak and a high plateau pressure, we're going to think about, do we need to decompress an pneumothorax? Do we need to look out for abdominal compartment syndrome? Or do we just have really bad lung injury from aspiration or from pulmonary contusions? If we have a situation where we have a high peak pressure but a low plateau pressure, now we're like, okay, is this whole situation causing their baseline asthma or COPD to act up? Or more importantly, are there a bunch of blood clots everywhere that I need to bronch the patient? And 3, if they have a low peak and a low plateau, now you're like, okay, am I dealing with a large air leak from my chest tube? And if that is the case, then am I getting my tidal volume? If not, then you got to troubleshoot by putting them on a volume-targeted mode of ventilation. So that's our initial first pass, read the vent, troubleshooting basic things that you need to fix right away. So you've done all that. Fantastic. Pat yourself on the back. The patient is still satting 70%. That brings us to number 2, strategies for hypoxemia. The first one is very, very simple, and it's just dealing with ventilator synchrony. Ventilator dyssynchrony can cause you all kinds of problems with hypoxemia, and it's low-hanging fruit to fix. Often these are young, healthy patients, and they may require a lot of sedation, and don't be afraid to do that. Now, yes, we all want to get neuro exams, 100%. Would it be nice if we could get serial neuro exams? Yes, it would. That being said, you know what the injured brain really doesn't like? Satting 70%, that's not helping. And so if we need to deeply sedate and even paralyze the patient, that's okay. And don't forget, a lot of these patients are about to go to IR or OR anyways, where they're going to be deeply sedated plus minus paralyzed. So low-hanging fruit, do whatever you need to do to sedate this patient deeply, and if it turns out you do need to paralyze them, even just giving an additional dose of rock to get them through, that is okay. A lot of your other initial strategies that are going to be specific to hypoxemia in trauma patients are based on the fact that in comparison with ARDS patients, these patients often have very non-homogeneous lung injury. So, ARDS, not all the time, but a lot of the time, is just pan-generalized, non-specific badness everywhere in the lungs. But in trauma patients, not necessarily. Maybe it was one side of their chest that really took the hit. So you will see the right side or the left side is significantly worse than the other side, or just their pulmonary contusions are super patchy. So what can you do to address this? Well, the first thing is positioning. But of course, one of the problems you run into in trauma patients that you don't run into so much with medical patients is that you can just sit a medical patient up because they're unlikely to have a bunch of other injuries that would limit you. So the very first thing that you want to do in these patients when you're like, oh, it'd be really nice if I could sit them up, is get some imaging and get the formal reads on your CTC spine and CTTNL spine as well as soon as possible so that you know what your degrees of freedom are. Do I actually need to do log roll? Do they have an unstable C-spine injury, or is it actually totally fine? Do I have some more degrees of freedom here? Now let's say either you can't get those reads Or you get them and okay, actually you don't have a ton of degrees of freedom. You can't sit them up. You always can just put them in reverse Trendelenburg, right? So you're basically keeping the bed flat and you're just shifting the entire thing so it's angling up. So that's one of the things that you do. But the other thing that you can do that can be incredibly helpful is putting their good side down. Now, if this is an option, this is something that's helped me enormously in the past. In this particular patient that we're talking about, just doing that, just turning them so that their good side, which in the case of this patient was their left side, was down, got us from like 72% to maybe 81, 82%. This can be very powerful if you can do it. Now, why? Why is it helpful to have their good side down? Well, you are basically using gravity to send the blood where the oxygen is. Because if you look at, for example, this patient's lungs, and clearly the left lung is a lot better looking than the right lung, that's where the oxygen is, and so that is where we want to also send the blood. Gravity is our friend, and by putting their good side down, we now send all of that blood where the oxygen is. Now, what you're actually doing here is improving their VQ matching, right? That's ultimately what you're trying to accomplish. Now, what if you can't do that? What if, as was the case in this particular patient, that, yeah, it'd be great to do that, but oh wait, this guy has to go to IR. And you know what IR is not excited about? Having the patient turned, hanging out, just lying there on their left side. They're like, no, we need our patient to be flat. So I was just excited because great, we got like 82% going well, and then IR is like, nope, you gotta lay him flat again. Okay. So what if you are in that situation, or you turn them with the good side down and they get a little bit better, but not enough better? You run with the principle of they have patchy lung injury. What you want to do is improve their VQ matching. And another way to do that is an inhaled pulmonary vasodilator to deal with shunt, to deal with dead space. And this is another way of pharmacologically, rather than positionally, sending the blood where the oxygen is. And so I actually did with this patient. I was like, I'm going to start an inhaled pulmonary vasodilator. And so your options are epoprostenol or nitric oxide. Now, in general, I am a big fan of using inhaled milrinone and nitroglycerin as pulmonary vasodilators, but not in this situation. I will do that in the ED all the time when I'm using those drugs in order to decrease right ventricular afterload, when I'm using them to decrease the pulmonary pressures. In this situation, when I'm using them to improve VQ matching, in that case, I actually kind of need epoprostenol and nitric oxide. Why? Because in this case, you really, really need to get things all the way down to the alveoli. And so you can't probably get away with milrinone or nitric oxide here. You got to use your real inhaled pulmonary vasodilators. And we did that in this patient, and it actually was able to get us a decent amount of oxygenation back. All right, next thing, PEEP optimization. I feel like optimizing PEEP is by far one of the most complicated things in all of medicine. I mean, the art of PEEP optimization is right up there with the art of fluid resuscitation. And that's not even talking about doing this in the trauma patient. I mean, firstly, the ARDS PEEP ladder just wasn't studied in these patients. This is not the patients that we're talking about here. And you also have a lot of other factors to deal with that you're not dealing with in your average ARDS patient. So big picture, what are you trying to accomplish by increasing PEEP in your trauma patient? Well, what you're trying to do is recruit your bad alveoli. So the alveoli in the bad part of your lung, you're trying to say, okay, let me pop those alveoli open so they can actually be participatory in the oxygenation process. However, sometimes those alveoli just aren't recruitable. Because what you want to do is try and recruit them, but what you don't want to do is overdistend the good alveoli. Because if the bad alveoli aren't recruitable, and so you're going up on the PEEP, you're not recruiting the bad alveoli, and you're just overdistending the good alveoli, what you have now accomplished is by increasing the pressure only in the good alveoli, you are now actually sending the blood over to the bad alveoli. And this is why sometimes going up on the PEEP in these patients can actually make your oxygenation worse, not better. Now, that's one reason might that happen. But there's another reason in the trauma patients that it may happen that you go up on the PEEP and your oxygenation gets worse. And the second and very important reason is the relationship between PEEP and pneumothorax. Because if you start going up on the PEEP, that could cause you to reaccumulate or newly accumulate a pneumothorax. And so, before you do the exercise of up-titrating the PEEP in your sick trauma patient, you need to make sure that you've dealt with the pneumothoraces. Make sure that your chest tubes are on suction. If you haven't done a chest x-ray recently, get another one or do an ultrasound. And as you are going up on the PEEP, you have to be watching that air leak. Is an air leak appearing as you're going up on the PEEP? Is the air leak now bubbling as you're going up on the PEEP? Are you convinced that you have big enough chest tubes in the first place? So it doesn't mean you need to be afraid of PEEP in these patients, because sometimes going up on the PEEP can really help you. You just have to understand that you have to be very mindful of the relationship between increasing PEEP and potentially worsening a pneumothorax, and be mindful of that and keeping an eye on it as you're doing your PEEP titration. But what about the other major thing that we are taught to do in ARDS patients, which is lung protective tidal volumes? Should we be religious about targeting a tidal volume of 6 cc's per kilo in the initial resuscitation phase in your sick lung in your trauma patient? Not necessarily. I mean, if you try and look into this literature, it turns out that the recommendations for doing low tidal volume ventilation in the sick lung injured trauma patient are pretty much based on the general ARDS recommendations, but the amount of evidence we have for this specifically in trauma patients is not much. And so we don't really know if there's a benefit specifically in trauma patients with pulmonary contusions, aspiration, lung injury, who also have all of their other traumatic injuries. Is it necessary to do low tidal volume ventilation initially? Now, would I like to do that? Sure. But my ability to do that and the issues thereof bring us to the third issue that we're going to talk about on vent management in the sick trauma patients, which is competing priorities. So in these patients, as like all critically ill patients, but especially in these patients, you can't have everything you want at the same time. And you really, really have to keep it in your head that the lungs do not exist in a vacuum, and what you do with the vent in these patients has major consequences for the other aspects of your resuscitation. And these patients often have a lot of different things going wrong with them, and hypoxemia and the lungs are one thing, but there's a lot of other things. So one of the first things that you have to think about, and becomes particularly important when you're doing a PEEP titration, is that positive pressure ventilation has hemodynamic consequences. Now, this is particularly pronounced if you have a patient with some kind of tamponade physiology. If you try and go up on the PEEP in a patient with tamponade, that is a great way to kill them. And so, if you're really in trouble, this is probably your patient, hopefully that they're opening the chest already. But if you go up on the PEEP and they suddenly start trying to die, you probably need to re-ultrasound them and make sure, one, they're not having worsening tamponade, and two, they don't now have a tension pneumothorax. But not just that. If you have a patient who's still really, really hypovolemic, they're actively bleeding, going up on positive pressure can make their hemodynamics worse. So you gotta be mindful of that, and often in order to be able to go up on the PEEP to the extent that you need to get their oxygenation better, you gotta volume resuscitate them. You gotta be aggressive with volume resuscitating. But this becomes a double-edged sword. Because of course, you need to blood resuscitate and volume resuscitate, obviously for your hemodynamics and tissue perfusion, but also so that you can give them the positive pressure ventilation that you need. At the same time, giving massive amounts too much volume is the opposite of help to inflamed lungs. Because inflamed lungs, no matter why they're inflamed, they act like a sponge, and they just suck all that volume right up. But unfortunately, unlike a sponge, you can't just wring them back out again. And so, bottom line, you have to resuscitate them adequately, but also avoid over resuscitation in these patients because they're going to start getting worse. And I've absolutely had it happen to me multiple times that I'm like, great, I can finally go up further on the PEEP. They're adequately resuscitated. I've given a bunch of blood. Ooh, and now my lungs are really, really bad. So it's a fine line you're trying to walk, and do your best to avoid over-resuscitation, and I'm especially attentive to unnecessarily crystalloid in these patients because it's really not going to help you. And so just be thoughtful about it. Don't overdo it with the crystalloid. And if you think that this patient is just massively vasodilated because they're so sick, you just replace their blood volume, this is also a situation that I might do early pressors, particularly because these patients are also the same ones who are needing a lot of sedation. So if I think they're super sursy, inflamed, and they're needing a lot of sedation, rather than slamming them with a bunch of crystalloid to get my blood pressure back after I've given them a bunch of blood, I might do some early vasopressin or some early norepinephrine. Now, another issue that we run into is the lethal triad. So in patients, the lethal triad of bleeding, which is our coagulopathy, hypothermia, and acidemia. And what you don't want is these patients to keep bleeding because, as we just talked about, if they're bleeding, that is not helping. One, because they're getting more unstable, it limits your PEEP, and two, because the more blood we have to give them, the worse it is for the lungs. So we really, really want to correct this acidemia. Now, they usually end up with a metabolic acidosis. What do we need to do on the vent when our patients have a metabolic acidosis? We need to increase our minute ventilation. We need to increase our respiratory rate and often our tidal volume to compensate for that metabolic acidosis. And this is often the problem with trying to prioritize low tidal volume 6 cc's per kilo in these trauma patients. Because in a medical ARDS patient, I might kind of be like, okay, I can live with a pH of 7.20 to maybe 7.25. That's fine. But if my patient's bleeding to death, I'm a lot less excited about letting their pH hang out in an acidemic range. And so this is one of those things. I can't have everything I want at the same time. And so for me, in the sick trauma patient with a bad metabolic acidosis who I'm actively resuscitating, I'm like, I don't actually have direct evidence that 6 cc's per kilo in the acute phase is going to help this patient. And I do think that acidemia is going to hurt this patient. So I am much more liberal with my tidal volumes in these patients because I can't have everything I want at the same time. And then I get them up in the ICU, I get them through the initial resuscitation phase, and now if I have the space to do a little bit less minute ventilation to come down on their tidal volume, fantastic, but in the acute phase, that's not necessarily my priority. Another competing factor that you often have here is dealing with traumatic brain injury. Because if your lungs are contused and you're bleeding everywhere, there's a decent chance your brain will also have taken a hit. And it turns out that the brain is very picky about things like your CO2 and your O2. Now, a normal brain deals with its pickiness about keeping things like CO2 and O2 and blood pressure in range by aggressive autoregulation. But the injured brain is not so great at autoregulation. So the injured brain starts depending more heavily on us to keep the CO2, the O2, and the blood pressure in tight ranges. And so what this means is that in an ARDS, non-brain injured patient, I'm willing to let my CO2 be pretty high. As long as their pH is okay, if their CO2 is hanging out in the 50s, 60s, I don't really care all that much as long as the pH is more or less okay. In my traumatic brain injury patient, I am a lot less excited about that. I am also a lot less excited about letting them be hypoxemic for a prolonged period. Now, we don't need to be targeting higher PaO2s than normal, right? Too much PaO2 is actually not helping you in these patients. 60s is fine for your PaO2, but in your normal ARDS patient, if they're hanging out in the mid to high 80s for a while, do I love it? No. I'm like, oh, but I can kind of live with it, sure. I'm a lot less excited about it when I'm like, I gotta get oxygen to that brain. The other thing that you have to deal with in these traumatic brain injury patients is that your neurosurgeons, are understandably going to be wanting you to get neuro exams. And I would love to be doing that, but if my patient is super sick and I have to paralyze them to get them to be synchronous with the vent, and that's the only way I'm getting their oxygenation back, this is another competing priority that is a moving target and that you just need to work through priority-wise when you're talking to the rest of your team. But balancing all of these things can become quite difficult in this polytrauma patient who also has traumatic brain injury. Lastly, VV ECMO. So let's say you're doing all these things, you're doing everything right, but you just cannot make it work. You can't get their oxygenation, their ventilation into a place that supports life, or at least not supporting life with all of your competing priorities. Can you do VV ECMO as a rescue option in these patients? Maybe. But this is another thing that is a lot more complicated in trauma patients than it is in straight ARDS patients. So thing number one, you have to feel fairly certain that you have a neuro exam. Does this patient have bleeding? Do they have bad DAI that we just haven't noticed yet? Did they come in intoxicated with a GCS of 3? Okay. Did they come in not intoxicated with a GCS of 3? Do you have a good reason to believe that you're going to have a neuro exam coming out on the other side of this? Then the most obvious thing is, if you're going to put them on ECMO, you got to give them heparin. And I'm not wild about doing that if I think that they're bleeding to death simultaneously. Now, that doesn't mean that you can't necessarily put them on VV ECMO, because you can transfuse them through it, but you need to know that you've either already controlled the bleeding or you're about to go somewhere to control the bleeding. So, is it a hard stop contraindication? No, but you gotta feel pretty confident that the bleeding is something you can get under control. The next thing you have to think about is, what's their pelvis like? Because if you're doing crash VV ECMO, you're about to need to use both femoral veins. Do you have both femoral veins intact? Do they have pelvic fractures and they're bleeding out of everything everywhere in their pelvis? That can also cause you problems. So, is it an option? Yes. Have we done it before? Yes, we have. But you got to be very thoughtful, very selective. And a lot of the time, patients that you might otherwise use VV ECMO is a really good option if they have lung injury. That means that you just can't keep their oxygenation and ventilation within life-sustaining parameters. It may not be an option because of other things going on with this trauma patient. So that is vent management in your acutely sick critical trauma patient. You're going to start by reading the vent, because your vent is a critical diagnostic tool to help you figure out why this patient might be hypoxemic. 2, you're going to employ some hypoxemia strategies that specifically take into account the patchy, non-homogeneous kind of lung injury these patients often have. Then, number 3, you're going to understand that you have some really significant competing priorities. You can't have everything you want at the same time. And a lot of your job in these patients where everything is going wrong, not just the lungs, is to balance those priorities. And finally, VV ECMO, if you're at a center they have it, is an option for rescue sometimes, but only in a very carefully selected group of patients. Now, in this particular patient, he actually got better. It was not the most relaxing night of my life, but we did a lot of these things, and he ended up leaving the ICU neuro intact. And so a lot of the things we've talked about, is there a big, long study talking about all of these things? No, because these patients are sick, they're complicated, and each one of them has their own unique set of problems, so I think it would be very difficult to do a study to come up with an optimal strategy that it would apply to each one, but hopefully this gave you a number of tools that you can use thoughtfully depending on the patient in front of you to get through when you have a situation of patient polytrauma setting 70. Thank you guys so much for listening.